Hello everyone, my name is HIM1012. I'm a lead data scientist at University of Utah. Today I would like to present our study on early prediction of bladder cancer diagnosis using structured claims data and machine learning. Hematuria is one of the most common presenting symptoms of bladder cancer. However, it is frequently misattributed to non-malignant conditions, such as urinary tract infection, particularly in primary care setting. This contributes to under-evaluation and delay in further urology assessment. Some studies shows that fewer than 50% of patients with hematuria ultimately receive a timely urology workup. Also, retrospective studies have shown that approximately 25% of bladder cancer patients experience diagnostic delays exceeding 3 months from their initial hematuria-related visits. These delays are associated with increasing staging severity and a higher likelihood of metastasis at the time of the diagnosis. This pattern also suggests that we need a systematic tool to identify patients for follow-up earlier in their care trajectory. So this study aims to develop predictive models for bladder cancer diagnosis using administrative claims data. Our goal was to predict cancer diagnosis 1 to 3 months before the formal date of the diagnosis. We focus on short-term prediction windows to assess whether existing healthcare utilization patterns could serve as early indicators. We use data from the MarketScan database using both the commercial claims and encounter subset and Medicare supplemental subset. The time period was from 2016 to 2019. These data sets contains de-identified administrative claims for over 250 million individuals in the United States. The dataset include detailed information on diagnosis, procedures, and outpatient prescription medication, all linked by patients, a patient ID across time. This allows for tracking of healthcare utilization across different providers and settings. And it will also allow us to capture care delivery across a variety of networks and specialties. For this study, we constructed a matched case control cohort. Cases were defined as patients with bladder cancer. We included those whose first diagnosis date was between 2016 and 2019. We identified these patients using ICD codes. To ensure capture baseline information, we require all patients to have at least 2 years of continuous enrollment in the dataset prior to their first cancer diagnosis date. Controls were selected from individuals with no record of cancer history. We included patients who are 50 years or older, and we performed 1-to-1 matching using propensity scores based on age, sex, Charlson Comorbidity Index, and diagnosis year. These are some of the demographic information between cancer and non-cancer patients. There are 5,469 cancer patients and the same number of non-cancer patients. The average age was similar between case and control at 67 years old, and so is the Charlson Comorbidity Index scores were similar between the case and control. There were around 72% of male patients and 28% of female patients in the case group. This proportion were consistent with the known higher incidence of bladder cancer in male patients. So to prepare features for our predictive model, we began by processing two mean data tables, the outpatient claims and the medication claims table. In the outpatient claims, we extracted both diagnosis code and procedures code. All ICD-9 code were first mapped into ICD-10 equivalents. From there, we used the clinical classification software refined by AHRQ to group all ICD-10 codes into 325 clinically meaningful diagnostic categories. Similarly, for CPT-4 procedure codes, we grouped them into 158 procedure categories. And then for a medication, we were working with the National Drug Code, and then these codes were mapped into 152 therapeutic class using the Red Book system. Once all these codes were categorized, we also generated additional counts for how frequently each group appear in the patient's 1 year observation window. In addition to these group features, we created several summary variables to represent the overall healthcare utilization pattern, such as total number of visits, total number of procedures, and total of medications per patient. The initial feature set include over 635 variables derived from structured claims data. To reduce dimensionality and maintain interpretability, we applied a domain-specific feature selection strategy. To do this, we trained separate XGBoost models using only features from each domain and ranked the variables by their game-based importance score. And from each domain-specific model, we selected the top 50 features, resulting in a more manageable set of predictors for the final model. So here is a correlation check. So before this feature selection, 7 sets of variable has very high correlation, where the correlation coefficient is larger than 0.8, and 50 sets of variables have high correlation, where the correlation coefficient is larger than 0.5. However, after the selection, only 1 set of variable has a high correlation, and 9 sets of variable has high correlation. So in terms of machine learning models, we selected XGBoost as our primary model for its strong performance in classification task. The prediction task was framed as a binary classification with the model to predict whether a patient would receive a bladder cancer diagnosis within 1, 2, or 3 months following the observation period. For each prediction window, we use a fixed 1-year observation window ending before the prediction month. For example, the 1 month ahead model used data from 1 to 13 months prior to the diagnosis. The 2 months ahead model used data from 2 to 14 months prior, and the 3 months ahead model used data from 3 to 15 months prior. This structure helped preserve the temporal separation between the predictor and outcome, and minimizing the risk a risk of data leakage from imminent diagnosis-related activity. So these are the model performance. The 1 month ahead model achieved the highest performance with an AUC of 0.81 and precision of 0.84. This suggests that recent clinical activity leading up to diagnosis contains strong predictive signals. When we extended the prediction window to 2 months ahead, model performance declined to the AUC score of 0.72, and 3 months ahead model has AUC score of 0.71. So this trend is expected as clinical indicators become less specific the further back we move from the diagnosis date. So over here, we've performed a feature importance analysis, and these plots were generated for each model. So hematuria consistently emerged as the most important feature across all 3 prediction windows. Other top-ranked features include urinary symptoms, urinary tract infection, and abdominal CT scan, which often represents early diagnosis steps. Endoscopic procedures and urinary tract biopsy were also predictors for 1 month ahead model. At longer prediction windows, like variables such as COPD and tobacco-related disorder gained more relatively importance. So these variables are likely to capturing the underlying risk factor or comorbidity patterns. So there are also several areas of improvement and then things we should do for our future work. First, we observed that prediction accuracy declined in longer forecast windows, suggesting that more distant signals are harder to distinguish. In addition, the use of uniform observation and prediction window across all patients may not fully represent the variability in real-world care trajectory. To address these limitations, we propose integrating unstructured clinical notes with claims data using large language models. So these clinical notes often contains relevant context, including symptoms onset, diagnosis reasoning, and test interpretation, which are not captured in structured data. Extracting this information can help with feature representation. Furthermore, we plan to adopt temporal models such as recurrent neural networks or transformer-based architectures. These models can help better capture sequential patterns, which could be useful in our analysis. In conclusion, this study showed the structural claims data can help predict bladder cancer before diagnosis. We use diagnostic code, procedures, and medication to model patient history and healthcare utilization patterns. The model reached an AUC score of 0.81 for 1 month ahead prediction. And the feature selection strategy really helped with the model performance, and it also reduced dimensionality and improved interpretability. It also preserved the most clinically informative signals across procedure, diagnosis, and medication. So in future works, we'll also include unstructured data, which will further improve our prediction accuracy. So that's all for my presentations. Thank you for listening.